from New Delhi, and it's my proud privilege to introduce Dr. Jonne, who is a PhD holder and also an assistant professor and technical physician at Radboud University Medical Center in the Department of Intensive Care and Neurology, where he leads the Clinical Neurophysiology Research Laboratory. He is a prominent expert in respiratory muscle physiology. His work focuses on the interaction between the brain, lungs, and the diaphragm to improve outcomes for mechanically ventilated patients. A number of awards has been credited to his account, and his academic excellence has been further recognized by the Netherlands Intensive Care Society and the Netherlands Respiratory Society for his landmark doctoral research on diaphragmatic function. He serves on the board of Journal of Respiration and Medical Advisory Boards of Getinge and Respinor. So I'm sure Dr. Jonne will be the best person to do justice to this topic. So welcome, Dr. Jonne, once again.
Thank you. Thank you very much for the nice introduction, and thank you for the invitation to speak today on this symposium. I'm very pleased to talk about diaphragms. So I'll start sharing my screen. We'll be talking about diaphragm dysfunction. So as in the introduction, I've been doing research on the diaphragm for over 20 years, I think, working on diaphragm research. And I'm happy to share some insights from our work in the past years on diaphragm dysfunction, particularly in the ICU. These are my conflicts of interest for this presentation, for grant support I received and consultation. So let's start with the diaphragm. So I think we all know what the diaphragm is. It's our respiratory pump, our main respiratory muscle. And it's located in the thorax as a kind of umbrella structure in the thorax. So today I will be almost only talking about the diaphragm, but I put this slide in just to realize that the respiratory pump is, of course, more than the diaphragm alone. We have a lot of accessory muscles that aid in inspiration as well, the intercostal muscles and the muscles in the neck, like the scalene and the sternocleido. And of course, the abdominal muscles are also important for expiration. So I think it's good that we primarily focus on the diaphragm in the ICU, but we should not forget about all the other muscles that contribute to breathing. So just to quickly make this remark, and now I'll focus on the diaphragm. I think, and this is not new for anybody, that we're aware that diaphragm dysfunction is very prominent in the ICU. So it's highly prevalent, and this has been demonstrated in numerous studies. And this is a paper from some years ago where you actually can see the decline in the pressure generating capacity of the diaphragm during following days in the ICU. So you can see that the force is declining. This was an important study. And I think also this study from a few years ago, which measured the prevalence of diaphragm dysfunction at the first spontaneous breathing trial patients were undergoing in the ICU. And here you can see that in patients with prolonged weaning, all the patients have diaphragm dysfunction. And also in patients with simple weaning, there's almost 40% of prevalence of diaphragm dysfunction. So I think there's no discussion that diaphragm dysfunction, diaphragm weakness is present in our patients in the ICU. And this affects outcome as well. So this has clinical consequences. Here you can see differences in the total duration of mechanical ventilation, length of stay on the ICU, hospital mortality, where there are differences between patients that do have diaphragm dysfunction and patients that do not have diaphragm dysfunction. So it's an important topic. And the question I want to address today is, what is the pathophysiology of diaphragm weakness in critically ill patients or diaphragm dysfunction? And I think this is important. because this can help us to formulate strategies and interventions to treat diaphragm dysfunction. Actually, recently we published this paper in Critical Care. It's still in the preprint, which discusses the different factors that contribute to diaphragm dysfunction. And here we specifically talk about critical illness associated diaphragm dysfunction, because I think it's important to realize that diaphragm dysfunction is not only caused by mechanical ventilation, but there are a lot of other factors in our critically ill patients that affect diaphragm dysfunction. So therefore, I'm more fan of the term critical illness associated diaphragm dysfunction than ventilator-induced diaphragm dysfunction, which I think is only a part of diaphragm dysfunction in the ICU. So there are factors related to mechanical ventilation and factors not related to mechanical ventilation, and I will discuss a few of these factors in this presentation. So let's start with factors related to mechanical ventilation, and I think these are the 4 categories of factors related to mechanical ventilation that can cause diaphragm dysfunction. So I think the first is the most known and the most studied is that controlled mechanical ventilation, where the diaphragm is not working, is not delivering any work of breathing, or over assistance in support modes, can lead to disuse atrophy. Like any muscle, the diaphragm needs to work, otherwise there's atrophy. Then there's more discussion on under assistance. So while on pressure support or any other supportive mode, giving too little support, leading to under assistance, making the diaphragm to work very hard, leading to load-induced myotrauma. But important, and I will discuss it later, the evidence here is still really thin. Then I will also talk about the effects of PEEP, and the other one is diaphragm activity during expiration or during periods of asynchrony, which may lead to eccentric myotrauma. I will not be going into detail discussing this possible cause of diaphragm dysfunction, because a lot of work on this topic is very experimental still. Okay, so let's continue. And we'll go with disuse atrophy. I think we're all aware of the study in 2008 by Levine in the New England demonstrating rapid disuse atrophy of the diaphragm. But this was in brain dead patients, and there can be metabolic mitochondrial changes here that may have affected the diaphragm as well. So I think this study by Hoyman in 2015 is maybe more representative or appropriate for our critically ill patients, our ICU population. And here they demonstrated in approximately 20 critically ill patients and 14 controls, where the patients were on average ventilated for 74 hours, that on average there was a reduction in, if you have slow and fast twitch combined, of approximately 25% of atrophy in 74 hours of mechanical ventilation. So yes, we see disuse atrophy or atrophy in our patients. But the question is, does this explain the severe weakness we observe in this patient? And I think the level of atrophy we see, for example, this 25% in reduction of muscle fiber size, is not completely explaining the level of weakness we see. So there's more than only disuse atrophy in RCU. And I will come back to this point later on. Okay, now let's discuss load-induced myotrauma. And there are studies not in ICU patients, but in patients, for example, doing high intensity loading protocols, inspiratory muscle training, which can lead to load-induced myotrauma. But please be aware that in these studies, there was a very high intensity load, something that we will not see in our patients in the ICU. But theoretically, this could happen. I think one of the most recent studies is this study in anesthesiology in last year by Capdeville, who studied this. And be aware, this is in a pig model. They looked at the inducing load-induced myotrauma in a model where the pigs were first 72 hours under controlled mechanical ventilation and then 2 hours of under assist. That was one group. You can see the group here. And the other group was only 2 hours on controlled mechanical ventilation and then 2 hours of under assist. So this is kind of a second hit model. So the first 72 hours were, for example, to induce atrophy, diffuse atrophy of the diaphragm, and then have the diaphragm with a high workload. While the other group, there was probably less pronounced diffuse atrophy in only 2 hours. And then you can see the difference. So what you see here is they did a phrenic nerve stimulation at different frequencies. So the higher the frequency, the higher the muscle force the diaphragm can build. And this is actually the pressure in the trachea that they measure. And then you can see this is before the 2 hours of under assist, and the dotted line is after 2 hours of under assist. And you can see that there's a decrease in the force generating capacity of the diaphragm in the group that first has 72 hours of controlled mechanical ventilation, while in the group that did not receive this longer period of controlled mechanical ventilation, there was no effect of under assist. So it seems also that under assist, the effect of under assist and load-induced myotrauma is also related to already a weakened diaphragm. But please be aware, this is in pigs. This is a model. And this has not been demonstrated yet in critically ill patients. And also, there are some discussions that even in this study that was designed for it, there's no correlation with effort, which is actually the hypothesis. So the esophageal pressure, so the respiratory effort was actually lower in the group with first 72 hours of controlled mechanical ventilation versus the other group. So there seems to be no relation between the respiratory effort and the development of diaphragm dysfunction in this specific study. And this is also maybe a bit complicated graph, but this is the differences before and after the 2 hours of under assist. And what you can see here is that the pigs with low effort or high effort, there's no gradation here. So the pigs with high effort did not have a higher change or decrease in diaphragm dysfunction. So this is also, there's no correlation with effort in the study, and there's no evidence yet in patients. So I think this is good to be aware of. Okay, now let's move on. So the third topic of the effects of mechanical ventilation I want to discuss is the effect of PEEP. And it's important to look at the effects of PEEP and the geometry of the diaphragm. So this is a very nicely performed study by Janssen some years ago in the Journal of Applied Physiology. And here, so what we did is having healthy subjects in the MRI while on PEEP. And you can see very nicely here, this is PEEP 2 centimeters of water, and here PEEP 15. And you can see that the diaphragm is pushed down. So it's pushed downwards by the higher PEEP. And this means that there's a change in the length tension properties of the diaphragm. And this can lead to a lower mechanical efficiency of the diaphragm. And this is something we typically also see in patients with COPD with dynamic hyperinflation. So the diaphragm flattens, making it less efficient for contraction and less efficient for generating force. And that's actually what's seen here. So this is the neuromechanical efficiency. So that's actually the pressure the diaphragm generates divided by the activation of the diaphragm, the EMG signal. And then you can see at higher PEEP that the diaphragm is less efficient to generate force. So this could also lead to diaphragm dysfunction. And this is also very interesting, and it's also very yet experimental, but I want to show it because it's a different concept. So when we think of atrophy, we think of muscle fibers getting thinner, but there's also something that's called longitudinal atrophy, and that's interesting. So let's have this hypothetical patient. We have a diaphragm at normal length. Then there's this certain overlap between the actin and the myosin, right? That's before mechanical ventilation. Okay, now let's induce PEEP, right? We apply PEEP in this patient, and the diaphragm is flatter. And then the muscle fibers are more close to each other, and the actin and myosin are in a less optimal position. So if this is for a long period, then, for example, if after a few days of mechanical ventilation, there is absorption of the length of the actin and the myosin to get the length tension curve, to restore the optimal length tension curve. So this is something that's demonstrated, which happens in our ICU patients. But now let's see what happens if we start weaning or trying to do a spontaneous breathing trial or extubate the patient, and we remove the PEEP. Then, of course, the fibers are again stretched to their normal length. And then this could also maybe lead to diaphragm weakness. So this is maybe an effect of mechanical ventilation, which should be studied further. All right. So what I discussed so far are factors that lead to diaphragm dysfunction, which are related to mechanical ventilation. But I think, this should be part 2, of course. That's a typo from me. But I'll move on now to factors that are not related to mechanical ventilation. And then, for example, we have to look at sepsis, inflammation, reduced calcium sensitivity, there are metabolic factors, and something we call diaphragm hibernation, which is a novel concept I will discuss. So I go into detail into a few topics I mention here. And we'll start with the effect of sepsis or inflammation. And this is a really nice and I think a very important study performed by Alexander de Moule in 2013, which showed that 64% of the patients admitted to the ICU have diaphragm dysfunction at admission. So this can have nothing to do with mechanical ventilation. I think that's important to realize. So a lot of patients are already weak, already have diaphragm dysfunction at admission. And then if we look into and this is of course some statistics, but if we look on what's the differences between these groups, then an independent factor is the presence of sepsis or not. So sepsis and inflammation is an important contributor to diaphragm dysfunction at admission. And this is interesting. This is a secondary analysis of this data and another study where they grouped patients with sepsis, where they measured this force generating capacity of the diaphragm, and then did a follow-up measure, the second measurement, typically around day 2, day 3. And then you can see there was even an increase in diaphragm function. So these were ventilated patients in the ICU where diaphragm function increased. And this is most likely because the underlying cause, the sepsis, was resolved. Okay, and this is extra evidence that inflammation occurs in the diaphragm. So these are different inflammatory biomarkers, and you can see that they're highly present in critically ill patients compared to controls. So this is also evidence of inflammatory processes that are present in the diaphragm in our patients in the ICU. This is also another cause of diaphragm dysfunction, which is called reduced calcium sensitivity. So as you know, the excitation-citation coupling within a muscle is triggered by calcium, right? And if you have a muscle fiber and you skim this muscle fiber from the diaphragm and you put this in a setup where you can measure the force and you can add calcium, you can get this force calcium curve. And here you see if you have controls, which is the top line, you can see at a certain concentration of calcium, you have, for example, 50% of the maximal force that this fiber can deliver. And in critical patients, for the same amount of calcium, there's a much lower force. So there's a reduced sensitivity to calcium in the muscle fibers, which could lead to diaphragm weakness as well. Okay, now this is a relatively new concept, at least for the diaphragm. This has been described in the heart, but not for the first time now also in the diaphragm. And it's called diaphragm hibernation. And I'll try to explain this a bit more in detail. So here we have the actin filament and the myosin filament. And normally, and I don't know if this is good to see on the screen, but of course there's the actin and there's the myosin, which is bound. And then there's this excitation contraction coupling. So there's a bound state and of course there's a relaxed state. But there is also a super relaxed state. So where the head of the myosin is bound even more to the filament. And this is called super relaxed state. And it's a kind of an energy sparing state. And this has been studied in ICU patients and controls. And what they found is that the percentage of myosin heads that are in this super relaxed state in critical patients is higher than in controls. And you can say that approximately 25% reduction of myosin heads, 25% less myosin heads are available to generate a contraction. So this means, so as I said, 25% less myosin heads available for contraction. And this is probably because this reduces metabolic activity, stress, ROS production of the diaphragm. So this is a kind of a hibernation. So this may be a kind of protective effect happening in the diaphragm, for example, in the acute phase in critical illness. But maybe it has some consequences during the weaning phase. As I thought, this is a relatively new concept, and we're now performing new studies in our ICUs to investigate this phenomenon in critically ill patients. So we're wondering, is this reversible? Is this desirable in the acute phase? So these are all questions we're now trying to answer in our ICU. Okay, so I'm almost finished with my talk, and I want to come back to one of my first slides. So I hope I made clear that there are factors related to mechanical ventilation and not related to mechanical ventilation that lead to diaphragm dysfunction. And I think it's important to have this kind of framework because this also affects our reasoning on strategies to treat diaphragm dysfunctions and to our research. And to give you one example is, for example, diaphragm pacing, which is really a hot topic right now. There are different studies coming out on the effect of diaphragm pacing, and also, for example, diaphragm pacing in the early phase of mechanical ventilation, during controlled mechanical ventilation, to prevent diaphragm atrophy. But I think here it's important to realize, as I discussed in the beginning, diaphragm atrophy is maybe only 25% of the problem, or maybe only accountable for a reduction in diaphragm force of 25%. And as illustrated in this viewpoint we published, but also in this figure, the only thing diaphragm pacing is targeting is this atrophy of the diaphragm. But it does not have an effect whether there's a phrenic neuropathy or a failure in the neuromuscular junction, and it doesn't have any effect on reduced calcium sensitivity, inflammation, fibrosis, or hibernation. On contrary, maybe diaphragm pacing can even be bad in the early phase of critical illness, in the acute phase when there's still inflammation going on. Because this diaphragm pacing may activate, for example, muscle fibers that are hibernating. We don't know, but it could be that pacing in the very early acute phase, for example, in septic patients, is something we should not do. So therefore, I think it's important to realize this and to have this framework of, and to understand the exact pathophysiology of diaphragm dysfunction, because it helps the development of our treatment. And for example, what maybe be another strategy is, for example, to tackle this reduced calcium sensitivity. So we demonstrated almost 14 years ago that levosimendan, which is a calcium activator, so it increases the calcium sensitivity in muscle fibers, that this led to an increased efficiency of the diaphragm when you administer this. So currently we're doing a large trial in the Netherlands, multi-center trial, where we're administering levosimendan to see if this improves ventilator-free days in critically ill patients. So this is a very different concept than diaphragm pacing, and targets the reduced calcium sensitivity as cause of diaphragm dysfunction. All right, so to conclude, I think it's important, and we know this, that diaphragm weakness and dysfunction is highly prevalent in the ICU, and it has clinical impact. Pathophysiology is very complex, and I'd rather talk about critical illness-associated diaphragm dysfunction instead of ventilator-induced diaphragm dysfunction. I think the term VIDD should be reserved for animal work where you're only investigating the effect of mechanical ventilation. And with this, I think that the pathophysiology should guide our therapeutic interventions or strategies for the treatment of diaphragm dysfunction. So I want to thank you for your attention, and I would be happy to answer any questions you may have.
Thank you, Dr. Jonne, for your outstanding presentation explaining the pathophysiology of ventilator-induced, or rather, I'll say diaphragmatic dysfunction in critical care in your terms, which I think it is quite apt also. So in the last decade, maybe after 2013, so there are a lot of research on the diaphragmatic protection in intensive care or prevention of difficult weaning and prolonged mechanical ventilation. Yep. So with the current understanding of multifactorial pathophysiology of diaphragmatic dysfunction, do you think that there will be a role of ventilator, rather in terms of that we discuss ventilator induced diaphragmatic dysfunction, so there should be a diaphragmatic protective ventilation strategy. So will it be feasible in near future as a clinical researcher in this area? Do you think will it be feasible to develop, which has been discussed in critical care in the last couple of years, obviously with very limited success and understanding. But what's your opinion on this?
Yes, so I think this is a most discussed topic as well. So to achieve lung protective ventilation and to achieve diaphragm protective ventilation, right? And I think from a very pragmatical point of view, of course, diaphragm protective ventilation, we can aim for a kind of physiological target that at least there is diaphragm activity, so we kind of prevent disuse, but very high activity, well, it may lead to injury to the diaphragm as well, but we're not really sure. But at least targeting a certain level of activity of the diaphragm, I think this is important to realize, that we're not giving too much supportive ventilation, or we also take this into account when transitioning from controlled mechanical ventilation to assisted ventilation. But I also think that we have to be honest here as well. There is more evidence, I think, for lung protective ventilation than diaphragm protective ventilation. So if you have to make a decision based on evidence, I would, although I'm a big fan of the diaphragm, I would first look at the lung. So are we delivering lung protective ventilation? Are we within the limits of dynamic transpulmonary pressures, etc.? And then look at the diaphragm. And especially maybe in the earlier phase of mechanical ventilation or admission to the ICU, the focus should be more on delivering lung protective ventilation. And while we're shifting in our patient journey on the ICU towards extubation, I think we should be more and more aware that we also take the diaphragm into account. But maybe first the lung and then the diaphragm. I think that's a bit my point of view. Yeah.
There is a question from the audience. What features can suggest diaphragm dysfunction clinically?
So what features can suggest? Okay. Yeah. It's a good question. And I think clinically, you would start noticing it when you have troubles in weaning your patient from mechanical ventilation. For example, if you're transitioning to assisted ventilation and there's a difficulty with spontaneous breathing and the diaphragm cannot generate enough force. So I think that's when you start noticing it in a clinical setting. Of course, there are techniques to monitor diaphragm function in the ICU. So this can give you a bit of an idea. The gold standard, of course, is doing twitch transdiaphragmatic pressures or twitch tracheal pressures, but this requires magnetic stimulation. I don't think every ICU has this equipment and this expertise. We perform this sometimes in our patients when we suspect the diaphragm weakness. But of course, if they're spontaneously breathing, you can also do maximal inspiratory pressures, measure the force the diaphragm generates. In this specific patient. And there's also, of course, a lot of discussion and a lot of work on diaphragm ultrasound and the role of diaphragm ultrasound. And I think if you look in large groups, you can see the development of diaphragm atrophy. But I think there's a lot of, if you do measurements in one specific patient, there's a lot of variation in this as well. So if you have a large group, and that's been in the studies, you can see a decline in diaphragm thickness, but it's very difficult to do this in one specific patient. It's not precise enough yet. Then we can look at diaphragm thickening also. And this, at least the diaphragm thickening, can give us an idea if the diaphragm contracts during mechanical ventilation. But diaphragm thickening itself is not very well related to the actual force the diaphragm generates. But how we use diaphragm ultrasound in our clinic is that when we have a patient it's difficult to wean from mechanical ventilation, we can use the diaphragm ultrasound to diagnose whether there's dysfunction of the diaphragm. So we can either rule out or confirm that there is diaphragm dysfunction. So I hope this answers the question.
Thank you, Dr. Jonne. It's an excellent discussion regarding the clinical understanding of diaphragmatic dysfunction. Dr. Tapesh, do you have any question, or can we conclude the session?
No. I think that was a wonderful talk by Dr. Jonne. Jonne, really appreciate the talk and your research work that you are doing. very exhilarating. And diaphragm is definitely a very big problem, diaphragm dysfunction in the critically ill, and the problems that it causes. So, Dr. Souvik, there are no questions in the audience also. So if you
Yeah,
could,
we can conclude.
yeah.
And thank you, Dr. John, once again for your time and wonderful presentation regarding this topic where you were continuing. Please do continue
You're
your
welcome.
research. Welcome. Thank you.
So thank you, Dr. John. Look forward to having you again with us on our educational program sometime. Thank you very much.
Yes, happy to join again. Thank you for
Bye-bye.
inviting.
Bye-bye. Take care. Take care.
Good luck. Bye-bye.
Thank you, Dr. Souvik. Take care.